Good afternoon, everyone. You are in the Open Data and COVID-19 session, applying science and technology to build greater health equity. I will give you a brief overview of the session, and then we'll turn it over to each of our guests to introduce themselves and tell you a little bit more about kind of them and their work. So the session description, the COVID-19 pandemic disproportionately impacted communities that have been historically underserved by kind of traditional government outreach. The office that I work in, along with the offices of the Assistant Secretary for Health, as well as the Center for, are going to talk about efforts to use data to help bridge this gap. And this session will focus on how available data that's impacted the response efforts and how we can build better health equity in communities that have been traditionally underserved or marginalized. My name is Kevin Duvall. I'm the Chief Data Officer for the Department of Health and Human Services. And I will turn it over to our panelists to introduce themselves and tell the audience a little bit about their work. So I will start with Alan from CDC.
Great, thanks, Kevin. Hi, everyone. I'm Alan Sim, epidemiologist and public health informatician by training, and I've been serving as CDC's first Chief Data Officer since December of 2020. Very excited to be in this role to help lead and move the agency forward in exploring novel ways in which we can collect, curate, analyze, generate insights to inform policy and decision making. But obviously, we do all of this for a reason. Not only to support public health reporting, decision-making, but also to improve public health outcomes, including reducing health disparities and improving equity. So very honored and glad to be a part of this panel. Thank you.
We will turn it over to Leith.
Great. Thanks, Kevin. Good afternoon, everybody. Thank you for dropping in for the session. My name is Leith States. I am currently in HHS serving as the acting director for the Office of Science and Medicine, and also as the chief medical officer for the Office of the Assistant Secretary for Health. I've been with the department since about October 2018, so I've at least been around for a couple years, and I came to the agency after serving about 10 years on active duty in the Navy. My training background is preventive medicine, addictions, and mental health, but increasingly, I've been pivoting towards areas of justice, equity, and then more broadly, kind of the social determinants of health. I'd separate those out because they are different terms that have different implications for different communities. So part of the work I do has been with data and how that does impact downstream communities that are classically thought of as vulnerable. Giving you a little bit more granularity on what my portfolio has looked like. I work on climate change and environmental justice right now, along with equity and health tech for looking at equity in
and rural populations. I also have a bit of work around
disparities in out-of-hospital cardiac arrest, and then just a variety of other areas of interest that ebb and flow with the interest of the Secretary or the Assistant Secretary of Health. So pleasure to be here and looking forward to the chat.
Last and certainly not least, Dr. Kristen Honey.
Hello, thanks so much, Kevin, and thanks for everyone who's joining us. Self-introduction, I'm originally from Maine, so big shout out to Open Maine, the Code for America brigade out there, doing awesome stuff in my home state. Then moved cross country to Stanford, undergrad degree, master's from UC Santa Cruz, and then took about 10 years before the PhD in interdisciplinary biology. But before becoming a scientist, I actually co-founded a technology company in the late 90s and survived the dot-com bubble burst and did the Silicon Valley scrappy entrepreneurship out of necessity. And then moved on to become a scientist and came to DC in 2013 as a AAAS Science and Technology Policy Fellow. And I ultimately ended up leading open data for federal government under the Obama administration. I worked in Obama Office of Science and Technology Policy for the last year and a half of that administration. And open data and the innovation that it fuels has really, really strong bipartisan support. And I was able to stay on in the Trump administration for a year and a half in the White House Office of Management Budget, again, leading open data, data interoperability, and a lot of innovation. In 2018, when it was clear the Foundations for Evidence-Based Policymaking Act, which basically makes open data law, when it was clear that was going to pass, I moved over to HHS, Health and Human Services. And it was the mission here that really, really attracted me to this space, because no matter what side of the aisle you're on, everyone agrees public health is a priority. COVID has showed us that we all can relate to health crises. We're all part of the solution. And then HHS advised the Chief Technology Officer. And currently I'm the Chief Data Scientist and leading the COVID-19 Diagnostics Informatic Project.
So we have quite a star-studded cast to talk about kind of COVID-19 and open data. So I will jump right in. This one's a little bit of a softball, but I think it's going to get some discussion going. So industry, corporations have been leveraging data and frankly big data for years to deliver customer insights. I'm sure everyone's had that one ad that was a little bit too targeted for their own liking. So how can we, the federal government, the public health apparatus of the U.S. government, leverage data to create a more equitable approach to public health intervention? So I will turn this over to Kristen. I guess we'll go back to kick us off, and then feel free to jump in, Alan and Leith.
Sure. To tell a story in equity and make sure we're having an equitable approach, the data can only tell us what we have visibility into, where we're collecting data. And often we're missing really important segments of society. And whether that's because they don't trust government or science or systems and they don't want to share, if we're not collecting it, we are flying blind. So some of my work, the COVID informatics work, came out of diagnostic questions. And we were asked by leadership, tell us where the disparities are. Tell us where there are inequities. Are we testing appropriately? And we ran a quick analysis with the information we had back in, I believe, September 2020. And the data was really, really poor. But what became clear was that we were over-testing, white communities because their positivity rates were so low. We were under-testing Latinx because the positivity rate was really, really high. And then with the African-American communities, it was about average. So the disparities were glaring even with very, very little data. But because the data was so poor, we pulled on this thread, and that turned into our entire COVID-19 diagnostics informatics project. So I guess what I would say here is that, yes, having equity and having the data lead us is important. But more important than that is making sure that the data is comprehensive and represents everyone who we want to serve. And when it's not, then I think rather than following the data, it's more important to get out there in the field, understand what's going on from the people, and then hopefully through that interaction, we can bridge those data gaps and collect it in new ways to represent everyone.
I know for a fact that CDC is pretty heavily leading a equity and data effort. So Alan, what are your thoughts here?
No, I thought Kristen did a great job summarizing the landscape. And I can say, at least from an agency perspective, we've always been interested and focused on health disparities, but especially in light of COVID and other societal events, dealing with discrimination. There's all sorts of issues that need to be studied and examined. And so at the agency level, as part of the Data Council, there is a working group that's focused on devoted solely to health or data equity. CDC is co-chairing that. We have an actual strategic plan that's being circulated amongst our leadership. Dr. Walensky has made this one of our top priorities. So I think what is the impact? I think the impact is that as we go about our daily business, that we're being very intentional and mindful from the hypothesis, from design, from analysis, that all of these things that Kristen sort of alluded to, that we're taking those things into account, and not just following the data, but having the full picture and providing proper context as we communicate out to the public. So thanks for that, Kevin.
Leith, what are your thoughts here?
So I think, I can, well, I guess I want to, echo my support for statements from Kristen and Alan. I think it's hugely important to think of this through an equity lens. At the same time, there are many moments when I cringe hearing these questions. And the reason for that is that I don't think the end point is equity. Equity gets us so far. Equity creates tools that can help us correct the injustice for a time being, right? And it's really, that's really been utilized well with COVID, right? I mean, rapid adoption, whether it's telehealth, the diagnostics platform that Kristen has been able to work so hard on and, impact so many folks at the deck plate level that are doing the good work of public health. But in this, I think, man, this is an acute measure, but wouldn't it be nice to look up and get past the data barriers that have led to the underrepresentation, the absence in the capture of data that has kind of characterized the, the push and pull of being underrepresented and being satisfied with just accepting that this is status quo. And I think that all of us, whether that's federal, state, or local, we've been able to see this for what it is in terms of the moment of change in public health and data acquisition and how we want to build this back better, right? And I just think there's an opportunity that shouldn't be lost in how we further refine that lens. But I fully agree with what Kristen and Alan said. The only other piece I would say is that, there have been some really nice tools that have been allowed by the flexibilities that FDA, CMS, even CDC have brought on board with, decentralized clinical trials, a more inclusive way to do demography, citizen science, the capacity to actually take real world data and potentially have that impact, where some of these larger op-divs that are so steeped in their archaic ways of thinking and practicing science and statistical analyses, it has a real power to affect change. So I will stop there before I go too far on a soapbox. But thanks for.
And that's a really good point. The data is the expression of the overall system. We're only seeing one kind of small facet of a systemic challenge that we need to address in healthcare and health in the United States. So that's an excellent point. So touched on the pandemic, but I want to hit on a specific point. So during the pandemic, we saw a lot of reporting that was required from the federal government, reaching out to health systems and local health departments. We've also seen disparities in access to testing sites as well as, vaccination. I mean, I think this is clear from kind of discussions as well as the data. Can you tell us a little bit about kind of the lessons we're learning from kind of what's currently going on, and what are some things that we can more acutely, use cases or examples? I'll start with Alan, and then go back to Leith as well.
So I guess I could speak at least from the burden perspective for our data providers and health departments. Public health traditionally has not been well funded, and our state, local, tribal partners are typically are in the trenches dealing with reporting from testing and vaccination information coming in multiple formats. And so going into this, thinking how we could change the paradigm, we partnered with U.S. Digital Service during COVID to improve the capture of COVID testing through something that's called the Simple Report. That's just a way to report data, again, from providers that are received in multiple formats in non-digital friendly manner. SDS leverages an agile development using human-centered design principles. They develop in sprints, iterating and refining as they learn more. And I think that's important for us as an agency to embrace new ways in which we can be more agile and flexible to tackle these complex problems. And then obviously extending it into the equity lane and how we can improve data collection and capture. So that's just a taste of some of the things that we've been doing on our end. Over.
Old ways that got us to this point are not going to get us to the future. So yeah, I wholeheartedly agree. Leith, want to turn it over.
Sure. So let me start by acknowledging the fact that I'm the only one on the panel without data in my title. So I am not a data scientist. I am a dumb doctor. So when I look at this, what I've had interaction with is the idea around vaccine hesitancy, right? The idea of underrepresentation, mistrust, the downstream impacts on health outcomes because of the issues that have been obviously laid more wide and bare with COVID. The thing I'll come back to is I'm a member of the American College of Preventive Medicine, and we put out a COVID statement. And the one contribution I had was that we need to recognize that as public health professionals, as community health providers, as clinicians, whatever the case may be, it's not enough to do what's always been done in the vein of what Alan was saying in terms of community because they don't trust us because XYZ happened in the past. Well, that is impactful and it's important, and in recognizing it, acknowledging it, you go 80, they go 20. I think that that's more than adequate. Again, as you know, the Band-Aid on the situation. And we've seen this with, I think, the reactions from what I think has been a robust and unified response from NIH, from HHS headquarters, from there other areas that are offering up their public health experts that are trusted community extenders, right? That can interact with community and help overcome barriers in their capacity, right? Understanding that when it comes down to it, it's going to be the faith leader, the doctor in the community level that is probably going to get it to the finish line. Coming on the back end from that, in terms of the data implications, there are upstream issues that I don't need to consider right now, but health literacy, data literacy, and overall literacy, right? Plain language, helping patients understand what it is we're doing and what is real and what is not. Along with the underrepresentation from the clinical trials area, I think that that's been a meaningful way to increase the self actualization, the capacity of a community to believe in its own ability to change or do for itself, to as the tools without the lens of the history that is attributed to kind of the current state and how the COVID pandemic has gone to this point. So that's all I'll say on that point.
Leith, I wouldn't sell yourself short in calling yourself a dumb doctor, because at least you're the kind of doctor who helps people. So I like both your points and Alan's points about, thinking outside the box and coming at it in different ways. Leith, you mentioned citizen science, coming at it in orthogonal ways, creating a space for different solvers to come together and offer ideas. And Kevin, you'd asked about use cases. So one use case, I think, in government where we're reducing the reporting burden. Going back to the original question of how do we reduce the reporting burden in the healthcare systems and departments, and make sure that we're bridging the disparities. So in the diagnostic space, their reporting burden, especially on the front line of what's positive, what's negative, there's always been a trade-off. Sometimes often it's paper and pen, reporting it, recording it, then transcribing paper and pen to an Excel file, uploading it, all that. Thinking outside the box and engaging other solvers from different fields where maybe technology is more advanced has allowed us to leverage tech so that reporting burden isn't just reduced, but in some cases eliminated. So there are tests now that are on the market. By taking the test, the results are automatically and wirelessly and anonymously sent, which is what you need for public health. In federal government, public health response, we need to know where the outbreaks are. We need to know positive, negative, what the rates are, trends. But even if you don't have, or you don't even need identifiable information in those cases, it's still really, really informative. So we were able to kind of think outside the box and how do you use technology to do that reporting for us so you can get out of the manual process. And one of the challenges we had is that time was limited. COVID was moving so fast, we needed solutions yesterday. So back in, I want to say December, November, the department put out a call for problem solvers everywhere around the globe to give us their ideas of how we could improve COVID reporting diagnostic results from the test itself to make it less friction for taking a test, to automatic reporting of it, to developing the infrastructure, wherever it was in the pipeline. We wanted your ideas. And over 1,000 people participated in this process. We did a 1-month crowdsourcing innovation sprint. Over 30 solutions were submitted, and of those, 15 or 16 were chosen by judges to join us for a technology sprint. And some of those winning teams that went on to this technology sprint that we've called the COVID-19 Top X Tech Sprint, modeled after the Obama White House and their The Opportunity Project. So huge shout out to Drew Zachary and all the top team who are now at Census running this whole program. We engaged 15 industry-led teams, and teams like IBM that is now rolling out their blockchain technology in New York City for passports. Teams like Illume, which is, and some of the aggregators like LifePoint, which have produced some of the tests that are automatically reporting in an anonymous way the results of COVID, so public health can know what's happening on the ground. We didn't know how to solve that, so we put out a call, and industry and solvers from everywhere kind of came out. So in terms of a use case, I think that thinking outside the box, when there's a fast-moving challenge, you can harness the resources, the talents, the strengths of all sectors in creative ways. And this civic tech movement, all the civic technologists out there are what have created the solutions in the space I work in. And I bet some watching are actually offered solutions or were part of the teams that submitted and built the digital tools. So thank you all for rolling up your sleeves and being part of our whole of society COVID response.
I can echo that point. A lot of the open data products that we put on healthdata.gov, every once in a while I'll get an email saying, hey, could you check this? Hey, could you look at this? And really the quality and focus that people in the civic tech community give to some of the products that are published, it fundamentally makes the products better. It's that wisdom of the crowd that really shows that people care, and shows that there's a lot of bright people out there using these open data products to do cool things for the American people. So you brought up kind of civic tech, and that's a form of collaboration. But I wanted to ask also kind of a broader question about who are some of the in your kind of vantage point in the COVID-19 response, who are some of the key people or groups you worked with, and then what are some of the key kind of principles that made those collaborations successful? Leith is our resident doctor. We'll turn it over to him first.
Thanks, Kevin. So I think, looking at the principles first, right? The understanding is we've all been operating at decreased margin bandwidth with our resources, whether that's emotional intelligence, whether that is capacity to handle home work, and the adjoining issues that have come with the extra hours, the weekends, whether we're healthcare workers or we're supporting the effort through other means, right? I think trust, communication, humility have been huge in terms of the principles that have driven us, at least looking at things from my window within OASH, where we do have the privilege to have that interface with not just the rest of HHS, but also across to the rest of the whole of government and with the White House in instances. So it's certainly required, practicing the golden rule and at the same time remaining focused on what's important. So when it comes down to it, getting lost in the whirlwind of everything, maintaining our focus, the trust, the humility, the communication have been by far the most important. I think of the key players that have been probably some of the more influential. I don't say this as and I want to say, let me frame it like this: influential in helping shape new thought around how we can respond better to public health emergencies and crises. And this isn't to knock on public health professionals and doctors. I'm both of those things, but we kind of get set in our ways because it feels comfortable to do it that way because that's how we've always done it. So the folks that have been most important and I think most meaningful in terms of their impact have been folks like Kristen, have been folks like those from the USDS, have been folks that have really kind of introduced, I think, some new ideas and thoughts that it's not as if there were not those thoughts and at least leanings within CDC or local state public health departments before, but it's almost given it a voice and kind of this, you actually can visualize it and then it becomes something that you want to chase after, right? Because then it's something tangible. Before it's just kind of that thing you don't whisper too loud. Now it's getting to the point where you're like, you know what, this is something that can happen. So that's my kind of short and sweet on that. That's somewhat helpful being a doctor.
I think you hit on a fun in this kind of pandemic, which was public health became front and center for every person. It wasn't kind of an esoteric practice that maybe people, everyone has some basic understanding of how the public health system works. Some obviously more than others. I think people on this call could write dissertations about it, but and that kind of non-expert kind of introduction into it, I think in many ways helps because these people maybe see through different vantage points and lenses. I'll turn it over to Kristen or Alan to kind of take it from there.
Yeah, I'd love to build on what you and Lee said and going back to that word trust. And I think that's so important. And so thinking about how we build trust, when we were doing a lot of our original COVID work in collaboration with CDC and across the entire department, we stood up a data sharing platform called HHS Protect. Kevin was instrumental in leading this effort. And very clearly from day one, we came up with 4 principles. And the whole reason for having these guiding principles was to build trust so that people would believe the data and the outputs of the data, and hopefully, the evidence-based decisions and policy recommendations and science coming out of that could steer our public response. So how do you build trust? The 4 principles we came up with were transparency, sharing, privacy, and security. And transparency is if you're working in the open, whether it's open source code, whether it's unlocking data, it's open data, And as Kevin said, having other people find flaws in it, see ways to improve it, work with us to continue responsibly unlocking more and more data. When you're working in the open, then people can understand what you're doing, hopefully also more the why you're doing, and the how. And that includes being transparent about methods, all of it. So we've done that on a lot of our work. Our innovation sprints, the COVID TopX tech sprint that we ran, for the first time ever, that was done totally in the open. All the demo days, all the office hours, all the meetings with subject matter experts of the department and the data stewards, that was open to all the public. And we did that intentionally to be transparent, to build trust. Sharing, why was that a principle for us to build trust? Sharing is that if everyone took that ethos and we all gave the data, the resources, the skill set that we could offer, we'd move forward in this crisis together. So that breaking down silos, breaking down the conventional sectors, disciplines, let's share what we have generously and we'll all move forward together farther and faster. The last two, privacy and security, might seem a little strange in building trust, but I think of this as about respecting boundaries. And if you respect people's boundaries, whether it's what you do with their private, their personally identified data or all of that, and you consistently have clear and ethical and consistent boundaries, and that includes privacy and security when you're using other people's data, keep doing that and you will build up trust. So those four principles is what I kept coming back to in the COVID response was transparency, sharing, privacy, and security. And all of that ultimately was hopefully to build trust across very diverse stakeholders.
You're CDC's first CDO, which is kind of a new and cross-cutting role.
Well, it's interesting. And standing up my enterprise data office, which was fairly new, I had to identify 3 core values, which I feel kind of dovetails nicely to what's been shared already. And the 3 core values were trust, collaboration or partnership, and then what I call meaningful modernization. And I think sometimes we get overwhelmed with the problem space, or we want to boil the ocean, so to speak. These are, these issues that we're facing right now as a society with COVID. I mean, we've dealt with pandemics before as an agency, but this one, the scale of this one just really overwhelmed our public health infrastructure. And I think this pandemic, more than others, forced us as an agency to look beyond our borders and to really depend upon our federal, state, local, tribal partners, industry, public. I mean, it truly was, it required everyone, all hands on deck, to come on board to think creatively. And so one of the things that we want to do as an agency going forward is to take those lessons learned and how can we tackle some of our historically, challenging problems and leverage some of the experiences and the partnerships that we've built. So anyway, just to go along with what's been shared, I think trust is sort of the cornerstone, but the partnerships and the meaningful thinking out of the box modernization activities has been very key.
Yeah, I want to amplify that, Alan, with the partnerships and all. And Kevin, your question asked also about key players. And so some of the key players we found headquarters were the data journalists and the people who really push us to be better. So it's a double-edged sword because your biggest critics are also the ones who help you the most. So huge shout out to all the data journalists out there, all the investigative journalists, all the people at COVID Tracking Project, US Digital Response. There were so many people who were willing to roll up their sleeves, get into the messy data, and give us really candid, often hard feedback, and speaking that truth to power. And there's a great model that has emerged out of this COVID, COVID response. And shout out to US Digital Service for pioneering this. But they were created a safe space of people who trusted one another enough, often built on long-term relationships. And this included data journalists and data scientists and investigative reporters and the data stewards in government. And in a very, very, very small group, we talked things through, and they were willing to sometimes go on an embargo and to kick the tires and look at data sets before we publicly release them. And that 24, 72-hour feedback ahead of big public unveiling of new data was incredibly helpful. It made the quality that much better. It was immensely valuable to us. So the data scientists, the data journalists, and all those journalists out there who push us to do better, we could not have done the response we've done without them. And this model of working collaboratively in small groups like that to problem solve together was so successful in COVID that U.S. Digital Service and our team here at headquarters, HHS headquarters, is working together to draft a playbook so we can share that method with others, and we hope to use it over and over again.
To extend the love fest a little bit for USDS, but one of their core values, build with users, not for users, and in many ways, that kind of exemplifies it. The consumers of these data products are those data journalists, and so that collaboration was really key to seeing the unknown unknowns in what we were doing. So yeah, I completely agree, Kristen. So switching kind of gears a little bit, but got to have a future tech question. But how can our data be paired? And I'll say it more broadly. How can our data be paired with X to better understand kind of the social determinants of health? So all these factors that are kind of our heterogeneous country faces in determinants of health. And how can we use that to improve outcomes for vulnerable populations? So kind of your pie in the sky, either future tech or collaboration. I will start with you, Alan, and maybe touch on some of your work that you're kind of spearheading now.
Sure, thanks, Kevin. I think, there's a recognition when you think about social determinants of health, you think of the issues that Leith so eloquently described before in terms of our systemic and structural barriers and the history. With that context, and then translating that context into actual applications in terms of data science and predictive modeling, we have to get that data somehow, right? Whether it's in traditional forms, whether it's through qualitative data, surveys, scraping of social media, utilizing natural language processing methods to take unstructured into structured. There's the technical aspect of it, but then there's the understanding where are those, how can we get the data sources from those populations? And then even more importantly, how do we integrate that data, ensure that we're doing it in an appropriate way as we develop predictive models, that we don't, being mindful that there's always a risk of algorithmic bias in model development, et cetera. So the ethical application of machine learning and AI is extremely vital and important. And then partnering with the community groups to sort of validate the assumptions that are being made. I think all of that needs to be really integrated when we start thinking about leveraging technology, leveraging machine learning and AI, et cetera, in integrating social determinants of health and other types of data sources. Thanks.
Often a lot of kind of college internship people, and that was a recurring question throughout. A lot of these social media platforms have a lot of this information, and I had to kind of remind them, well, that's the compact government and our citizens is different than the relationship kind of a social media platform has with its users. So yeah, that's but totally agree with you. It's about respecting and ensuring trust, as well as ensuring privacy as well. Leith, how about you? What's your crystal ball for new tech or maybe new methods here?
Well, so Alan brought up so many good points. I think this is such a fun question, right? It's I've been fortunate to work with a few groups across HHS that are focusing on this area. And this is just to give the brief history, right? So the CDC has their Social Vulnerability Index, and that's been around for multiple years. You identify areas of community vulnerability. It's kind of based in, your standard data collection methods. There's not much in terms of modeling there at this point, right? There are also some new entrants that are starting to kind of, I think, bring in some of the new thoughts around modeling that we're hoping around vulnerability and the social determinants. I've been working with the Census Bureau a little bit and looking at their community risk estimator, which came out last year. And they use ACS data, the American Community Survey, but they're doing something with, again, not a data scientist, synthetic, I'm gonna butcher this up here. They're looking at using something with synthetic methods to develop their predictive modeling capacity. Vulnerability. So they've been actively working with folks like EPA, with CDC, and there's SVI folks and the Environmental Public Health Tracking Tool folks to learn about what overlaps can be leveraged, what redundancies can be removed, and how can we do this in a way that's going to respect data privacy. And then at the same time, the biggest concern is validation at the community level. Is this going to be useful? And then are we going to get in the problems of bias that Alan was just discussing? That's really been a huge issue that's come up. If you all know a little bit of kind of your operating divisions within HHS, there's one called ARC, the Agency for Healthcare Research and Quality. And they've actually been looking into this question of how and ethnic biases can be introduced into clinical algorithm development. So it's a very rapidly developing evidence base, and will certainly have a ready application to public health. So it's an exciting area. I think it's a pie in the sky, but I think it's close. The right people are having the discussions, and it's getting to a point where I think it's exciting, not only because of the HHS support, but because of how much interest there is from external partners like EPA and already mentioned USDS. And then so much of this is led by OSTP as well as a kind of the hub. So it's a really interesting time and fun to be part of.
Yeah, building off of that, totally agree with both. And the question of how can AI and emerging tech advance the space and what's next on the horizon. I kind of think we need to crawl before we can run. And often the data, at least the data I work with, is so poor, I can't imagine unleashing machine learning on it or emerging technologies and all. We need the basics. And I think of the basics as going back to the people we're trying to serve and what problem are we trying to solve. And I think this is really, really critical on social determinants of health, because how you define health and wellness will vary by individual and vary by community. Not everyone wants the same thing. And so we might, if we take a technology solution, be absolutely making something faster, but solving or optimizing the wrong thing that the people we're working for may not even value. So I would sort of say it's not the AI emerging tech front as much as it is going back and re-engaging with the people who hopefully will co-create solutions with us. And so then what is on the horizon? What's the next big thing in that framework? And I would say the emerging technologies to empower patients and the lived experience. There are many, many types of evidence and many, many ways of knowing. But medicine is often, caught in a frequentist statistical approach where double-blind clinical trials is the gold standard. And the reality is there are many, many different methods out there to integrate different types of information to create informed decisions and decision intelligence tools. Most fields or many fields use, Bayesian statistics, like a good example, climate change. In climate change, we only have one Earth to work with. We don't get to do random, trials and have controls, because guess what? We have one Earth. How do they do that? They have many, many different sources of knowing and different priors, like what they think is going to happen. Different experts, different models predict certain things that can go into the framework. So if you define evidence broadly and you come up with more sophisticated models that are used in many, many other places, and medicine and our department is doing great things with adaptive clinical trials and leaning into this Bayesian approach, what that does is it creates a whole new frontier for patients, for caregivers, for that lived experience to be taken as an input for our decision making, where in the past it was left up to the experts in a one-way kind of top-down, here's what the experts say, here are the doctor's orders, go do it. But I feel like emerging technology is now going to be distributed two-way, and we'll come up with more sophisticated approaches so that the patients and the people who know a disease arguably better than anyone else in the world, because it's their body and they've been living with it for a long time, that information can be rolled into all the more conventional, double-blind clinical trials, academic research, laboratory studies, and it won't be invisible, it has. And so the emerging technology front to bring patient lived experience and caregiver lived experience into all levels of decision making, to me is a super exciting frontier.
So I heard in that, actually, Kristen, a decent bit of kind of the government's role in this. So that's an interesting point. So what's one thing that the government, our side, can do to ensure we're moving towards this goal of creating a more equitable public health system? I kind of heard a little bit with how we could think about clinical trials differently and what's possible there, but we'll open that. Well, we'll go back to our doctor because he, I'm sure, has a.
Well, I think I'll go with maybe the road less traveled answer here. And this is where, most public health folks will, just pull their hair out. Obviously, I don't do that, but with SARS, with MERS, H1N1, Ebola, we had opportunities to make public health a priority and fund it appropriately. And that was never the case. And I think that's largely for preparedness and response globally, right? If you look at Homeland Security, if you look at CDC, if you look at the rest of our preparedness apparatus with ASPR, and looking at Strategic National Stockpile, it just has language not been given the care needed. So of course it's going to die on the vine. So I will come back to, developing the relationships and providing the funding necessary to make public health a priority. I know there are a variety of other things that need to be done, government should and can be doing, but I will leave those to Alan and Kristen.
It's the dividends of good public health now versus kind of the expense of the COVID-19 pandemic. There are definitely orders of magnitude differences there. Alan?
So it's kind of interesting. We went to No One Is Noticing Us at the gymnasium and the high school party to now everyone is looking at us. And, we got the pimples and the, not so fashionable clothes on. And so we're trying to figure out, I think the public health community, with the executive orders, with the increase in funding, there's so many things, so many challenges that we've got to fix and tackle. What are those things that we need to focus on, for short term, medium term, long term? Who are those important stakeholders or partners that will help us get to where we need to go? And something that I've spent a lot of time in my first 4 months is getting us out of the silo condition specific mentality and thinking more about the enterprise public health as, as an agency with partnerships to solve problems and breaking things down into public health functions rather than on specific systems. And that's a cultural change across the board. But I've been very pleased that many people have acknowledged and recognized, as Leith mentioned, the previous pandemics, et cetera. We have a real opportunity to a paradigm shift here to change the way that we do business, and hopefully can change the way we're funded as well, because that's certainly a driver to that behavior. But all the things that were discussed in the previous questions, where we've seen opportunities in the way we've responded during this pandemic, this is the time to make that major transformative shift in the way we do business.
100%. And Alan, I've gotten an opportunity to know a lot of CDC people over the past, 14 or 15 months, and incredibly bright, dedicated individuals that are really trying to make a difference in the world. And so I'm 100% on board with that. If we can find new ways of working and engaging, that helps unlock and further that and expands kind of the role of public health, given we all know how important it is. I think that is a win for CDC. It's a win for America. So Kristen, over to you.
Thanks. So what's the big thing that government can do? My first suggestion is radical transparency and work in the open and explain what we're doing. And as we found in the open data space, often that will be uncomfortable. It'll be confronting because people will publicly see our flaws, point them out, but ultimately those pointing out the flaws will help us improve the quality and how we operate over time. It'll challenge us, but I think that radical transparency and a new way of doing business fits in line really nicely with what Alan was saying, and transformative change, and really thinking about how default to open won't just be for data, but how we do public health and government operations. So in the transparent space, then what can government do? And I think one of the biggest things that we can do, at least from HHS headquarters, is connect the dots across different agencies or across different disciplines or across different types of data that wouldn't otherwise connect. And we've done some of that in the social disparities and the equity space, and we're just getting started. So today, for example, just today, we published a new data set on healthdata.gov. And this is the COVID-19 community vulnerability crosswalk. So if you go to healthdata.gov, you'll see it. There's a blog, so you can read a blog about it. But this information that we pulled together, so it's machine readable, easy to digest, easy to understand, tagged with appropriate metadata so people can discover it. Once it's more discoverable, more usable, we can create value and real insights from that. All of the information in this data set was already available. It was out there in the world, some of it on the FCC website, some of it buried in our websites. And we had to internally organize it all and put it into one place for ourselves. And we just thought, this is valuable now that we've cleaned it up, organized it for ourselves. Why don't we share that with the world? So I think that model and open data has been a great example in the COVID space of what we can do. So working in the open and then really being a connector, and groups that might not otherwise talk, disciplines that might not otherwise see each other, make sure we are that glue and connecting folks so that together we're solving problems.
That's a fantastic segue. So there's two questions. I will read the first one. I think this might be a good one for Alan, because I know some of the work you're doing here. So do you see any necessary changes to the interagency data sharing agreement process to help speed some of the initiatives you've mentioned? Are there efforts to make these agreements more transparent? And I might have a word or two to say about that as well, Alan, but I'll start with you.
Absolutely. I think it sort of follows what Kristen was sharing, that the data is in different pockets of our agency space, and we just need to find ways in putting it together. One of those formal ways is through interagency agreements. I think part of the challenge with interagency agreements is that between the 2 or 3 parties that are sharing data, every situation seems to be a new customized agreement. And wouldn't it be nice if we could set some standard criteria for core data sharing kinds of activities and streamline that whole process and make it more defined internally within our own agency and across agencies on what the process should be to get those things approved. One thing that I'm working on right now related to that is getting our policy POCs and SMEs together. Because what I've found is that people who have been serving as data stewards for so long and pass that along to another data steward, some information that may have been pertinent back when isn't applicable anymore, or things change and legislation changes. So having sort of the ground truth on policies related to data sharing and making that more visible, so that when we define those use cases in which we need to share data, like through interagency data sharing, it becomes clear what our policies are to support that.
All right, so I think we have time for one more question, and I actually think this one's a good one to end on. So focus on medical transparency. We'll have to tag Kristen or tweet with Kristen's handle on that. But how can the tech and data professionals in this community help contribute to furthering your missions? And I will start with Kristen.
Sure. I think there are many, many different ways to get engaged. But with Code for America and the local brigades, my first, recommendation is look in your own neighborhood and see if there's an active chapter, because local government, where the rubber meets the road, and issues that are a priority to your neighbors, that's a great place to start. There are a lot of opportunities at the state level and, of course, federal government. And in the COVID space, U.S. Digital Response has really done a great job of matching up volunteers and connecting them to all levels of government, where skill sets can be matched to need. So I would say find a problem that interests you, and then look around who's solving it, and just reach out. There are probably many pathways for you to get onboarded, and when you offer to help, where there's a will, there's a way.
What about you?
That was really good and complete and concise. I think, the only additional thing I would say is there are some of us in other parts of the federal government that still may be a little more archaic and go through USA Jobs. So that is still a wonderful way to at least understand what positions are out there. And it's a way to match your skill set with what potential hiring agencies are looking for in their respective divisions. So I think that's a really nice way to go through it the formal, albeit the long way, because nothing is short in government, but it can at least be a good way to put your toe in the water. Otherwise, I think that USDS is a really great option. I know that they do they're heavy on recruiting, but their model is such a great one to follow, that I would say potentially reaching out to those folks and seeing where they have understanding and visibility into the gaps in given agencies, that can always help smooth things forward for you.
So from a workforce and internship fellowship perspective, I'm a product of CDC's Public Health Informatics Fellowship Program. I was in the 3rd graduating class. Young man working on data standards, didn't know anything about it 20 years ago. And so I encourage those aspiring data scientists and informaticians to look at what fellowships and internships are available. And if you are civic minded and you want to help the federal agency and public health agencies to solve really important problems, by all means, join and make a difference. You can make a difference even as early as year 1, year 2 of your fellowship. So encourage folks to look into those programs.
And I'll answer that one. Before I joined the government, you kind of see this amorphous thing that is the U.S. government. What is this? It's it's very complex. But at the end of the day, it's powered by people just like you. And so it takes those connections to solve big problems and working together. So I would just encourage you to reach out and engage because this is your government too. So we'll end on that note. Thank you so much for joining the panel. And thank you for listening to Kristen, Leith, and Alan talk about their experiences. Have a great day.